Hello, everyone, and a very warm welcome. Cholo, let's start today's topic, which is absolutely central to your understanding of pathology, the diseases of our white blood cells. I want you to pay close attention because what we discuss today will form the foundation for so much of what you'll learn in medicine.
Socho, just think about it for a second. Your body right now is like a perfectly conducted orchestra with millions of new blood cells being produced every single second. It's a masterpiece of biological organization. But what happens if one musician decides to play their own tune? Total chaos, right? Well, that is exactly what we are here to understand today, that journey from perfect order to complete disorder. So here's our plan for today. Simple, no? First, we'll tour the blood cell factory. Then we'll see what happens when the factory has problems, too few soldiers or too many. And finally, we will get into the really serious stuff, what happens when these cells go rogue. So let's begin. Right then, first things first, and this is a rule I want you to remember for your entire medical career. Before you study the abnormal, you must master the normal. You have to know how the machine is supposed to work before you can figure out why it's broken. So let's start with this incredible process called hematopoiesis. So what is this big word, hematopoiesis? Array, it's nothing but your body's own blood cell factory. And what a factory it is. Hidden deep inside your bone marrow, working nonstop, 24/7, from the day you were born until your very last day. Amazing, isn't it?
Now look at this. This is the family tree of our blood cells. And right at the top, the king, the great-grandfather of them all, is this one cell, the hematopoietic stem cell, or HSC. Every single one of your blood cells, whatever its function, can trace its ancestry back to this one superhero cell.
So this is the magic, okay? This cell has two incredible superpowers. First, pluripotency, meaning it has the potential to become any type of blood cell. And second, self-renewal. This is the really clever part. Every time it divides, it's like it tells one daughter cell, okay, you go off and serve the body. But to the other, it says, you stay here with me. We have to keep the factory running for a lifetime. It's brilliant, no?
Okay, so that's the ideal situation. The factory is running perfectly. But now, let's look at the problems. What happens when the production line slows down? When your body's army doesn't have enough soldiers, we call this condition leukopenia. Leukopenia. Leuco is white, penia is less, so fewer white blood cells, simple. But the one we really worry about in the clinic is neutropenia, a shortage of neutrophils. And why is that? RA, because neutrophils are your body's police force. They are the first responders against bacteria. If they are not there, any small infection can become a major life-threatening crisis.
So if your soldiers are missing in action, there can only be two reasons, right? It's simple logic. One, the factory in the bone marrow isn't making enough of them. That's a production problem. Or two, the soldiers are being killed too quickly on the front lines. That's a destruction problem. All causes of neutropenia will fall into one of these two buckets. Now, listen carefully. This slide is 5-star important for your exams, especially that second point, drugs. I am telling you, this is a pet question for the examiners. They will ask you, what is the most common cause of agranulocytosis? And you will confidently reply, drug toxicity, sir. Why? Because drugs like chemotherapy are designed to kill rapidly dividing cells. And what is one of the most rapidly dividing tissues in our body? Our bone marrow factory, of course. All right, let's flip the coin. We've talked about having too few soldiers. But now, what happens when there's a real threat, an invasion? Does the body panic? No. It does what any good army does. It calls for reinforcements. This is a normal, controlled response called a reactive proliferation. And look how smart the body is. It doesn't just send out a random mob of cells. No. For a bacterial infection, it calls up the neutrophil specialists. Got a parasite or an allergy? Here come the eosinophils. A virus? Send in the lymphocytes. The body knows exactly which expert to call for every single job. Wow, now look at this beautiful slide. This is a picture of a soldier right from the front lines. This is a neutrophil that is fighting hard. You see those dark purple spots, the toxic granulations? And that little blue smudge there, the Dolly body? That's the sign of a cell that was made in a hurry, pushed out of the factory before it was fully polished, because it was needed urgently on the battlefield. And what about back at the command center, the lymph node? It's like the Army's war room, completely buzzing with activity. You can see here how the B-cell training grounds, which we call follicles, they get all swollen and big. This is follicular hyperplasia. It means the body is gearing up, producing weapons, antibodies, for the big fight. But there's a dark side. All this growth we've seen so far is controlled. It's a response. It stops when the enemy is defeated. But what if it doesn't stop? What if the soldiers refuse to listen to commands and just keep multiplying? That, my students, is when things get very serious. That is neoplasia. That is cancer. Okay, 2 words you must know the difference between: leukemia and lymphoma. It's actually quite simple. Leukemia, think of it as a liquid cancer. It's in the blood, in the marrow, it's flowing everywhere. Lymphoma, think solid. It starts as a lump, a discrete mass, usually in a lymph node or other tissue. Liquid versus solid. Please remember that. But why? This is the fundamental question in all of cancer biology. Why does a cell that is meant to protect you suddenly turn against you? Well, it isn't random. There's a sort of blueprint for disaster, a sequence of unfortunate events at the molecular level. It usually comes down to 3 major problems. Think of it like a faulty car. First, a mutation happens that jams the accelerator pedal to the floor. The cell just gets the signal, go, go, go. Second, the gear gets stuck. The cell never grows up, it never matures, it just stays in a state where all it can do is divide. And third, someone cuts the brake lines. The cell loses its ability to die. So you have a car that's always accelerating, can't mature, and has no brakes. What do you get? A crash. You get cancer. And here is the great irony of our immune system. To protect us from every possible germ, our B cells have to create millions of different antibodies. And to do this, they literally cut and paste their own DNA in a process that is very high risk. And sometimes, just by accident, when they're cutting and pasting, they switch on a bad gene, a cancer-causing gene. So the very process that makes our immune system so powerful also makes it vulnerable. It is a true double-edged sword.
So as you can imagine, with so many different cells and so many things that can go wrong, we end up with a huge list of different cancers. It can be very confusing. So how do we bring order to this chaos? We classify them. In the Bible for this, the one system everyone in the world follows is the WHO classification.
Now, when you first see this table, I know, it looks very intimidating. So many names, but don't worry. The logic behind it is very, very simple. It's all based on one question. Which cell is the culprit? Where did the cancer start? Was it a baby B cell, a grown-up T cell? The name of the cancer is basically the address of the criminal, and we will build on this simple framework. So today we have looked at a lot of pathology, a lot of things going wrong, but I want you to leave this lecture with a different perspective. Don't just think about the chaos. Think about the order. Think about the trillions of cell divisions that happen correctly every single day inside your body. The disease is the exception. The miracle, the real wonder, is health. The fact that this unbelievably complex system works at all, that is something to be truly amazed by. Cello, thank you, everyone.
All right, everyone, namaste, and welcome back. I know, lymphoid neoplasms. This chapter can feel like a real headache, but fear not. Today, we're going to crack this code together. We're going to make this so simple, so straightforward, that you'll feel like a pro by the end of it. Cello, let's get started.
So, what's on the menu today? First, we'll cover the basics. What are these things anyway? Then we'll dive into the fast and furious tumors, the really aggressive ones. After that, we'll slow it down a bit and talk about the slow and steady types. Then we'll tackle the big one, the most common lymphoma out there. And of course, I've got you covered with a high-yield summary slide at the end, perfect for that last-minute exam prep. Simple, right? Let's go!
Okay, so first things first. Before we can really understand these diseases, we've got to know where they come from, right? It's like you need to know the villain's origin story. So let's take a look at the family tree of these troublemakers.
Right, now look at this chart. It might seem complicated, but I promise you it's actually super simple. Think of it as the family tree, the khandan of our B cells and T cells. They all start from one common ancestor, this lymphoid precursor, and then they mature, they grow up, they go through different stages of life, just like us. Now, a lymphoid neoplasm, that's just what happens when a cell at one specific stage, say a teenage pre-B cell, decides, you know what, I'm done growing up. I'm just going to stay here and make millions of copies of myself. And boom, that's how you get acute lymphoblastic leukemia, or ALL. Or maybe it's a more mature cell, one living in the germinal center that goes rogue. Then you might get something like Burkitt or follicular lymphoma. So the main point, the thing you absolutely have to get, is that the type of cancer depends entirely on which cell went bad and at what stage of its life.
All right, let's jump into our first big category. I call these the fast and furious tumors, and believe me, they live up to the name. These are the ones that don't mess around. They show up suddenly, they hit hard, and you have to act fast. Super important for your exams, so pay close attention. So, we've got two big players in this category. First up, acute lymphoblastic leukemia, ALL. This is the one you hear about in kids. It's the most common childhood cancer. And the onset is like a storm. One day the child is fine, the next they have a high fever, bleeding, fatigue. Why? Because the bone marrow has been completely overrun by these cancer cells. Then, on the other side, we have Burkitt's lymphoma. And guys, this thing is one of the fastest growing tumors in humans, period. It usually presents as a rapidly expanding mass, often in the jaw or the abdomen of a child or young adult. Now, this is what they look like under the microscope. On the left, that's AML. You just see this sea of blue dots, right? Those are the lymphoblasts, very immature cells. But look at the right. Wow. That is the classic textbook, absolutely will be on your exam, starry sky pattern of Burkitt lymphoma. It's beautiful in a pathological way. The dark blue sky is made of all the tumor cells packed together. And the white dots, the stars, those are actually macrophages, little garbage collector cells eating up the dead tumor cells because they're growing and dying so incredibly fast. You see this in your spotters, you write Burkitt lymphoma, no hesitation. So, the big question is why? Why does Burkitt's grow like a wildfire? Well, it all comes down to a specific genetic mistake, a translocation. Basically, a piece of chromosome 8 breaks off and sticks onto chromosome 14. Now, this moves a gene called MYC, think of MYC as the accelerator pedal of a cell, right next to a super powerful engine. The analogy I love is this. It's like taking the accelerator from a Maruti 800 and welding it to the floor of a Formula One race car. What do you get? Insane, out of control, unbelievably fast growth. That's Burkitt's. Okay, so we've done the high-speed chase. Now, let's pull a complete 180. We're going from the fast and furious to, well, the slow and steady. These are the indolent neoplasms. Indolent is just a fancy word for lazy or slow growing. These guys take their sweet time. In fact, they grow so slowly that a person can have one for years and not even have a clue.
In this category, we have two other big names you need to know. First is CLL, chronic lymphocytic leukemia. This is the most common leukemia you'll see in older adults, and it's sneaky. A lot of times it's found completely by accident on a routine blood test. Then there's follicular lymphoma. This one usually presents with painless swollen lymph nodes all over the body, and patients will often tell you something very characteristic. Doctor, these lumps, they come and go. That's what we call a waxing and waning course. It's a huge clue.
Let's look at the blood smear for CLL. You see all those small, mature-looking lymphocytes? Okay, fine. But what are these? These things that look like, well, like someone smudged the slide? That's exactly what they are. They're called smudge cells. And let me tell you, this is a gift from the examiner. These are just the fragile little leukemia cells that got crushed when the technician was preparing the smear. You see smudge cells, your brain should immediately think CLL. It's that specific. And for follicular lymphoma? Well, the clue is right there in the name, follicular. So when you look at a biopsy of the lymph node, you see it's packed with these little balls, these nodules or follicles. Back to back, no space in between. And why? Because that's where the cancer started. It comes from the B cells that normally live inside the lymph node's germinal centers, or follicles. So remember our car analogy? If Burkitt's was a stuck accelerator, follicular lymphoma is the opposite. It's a problem with the brakes. They've completely failed. And here's how. There's another translocation, T14-18, that messes with a gene called BCL2. Now, BCL2's job is to prevent cell death. It's an anti-apoptosis protein. It tells the cell, don't die, keep living. So this translocation makes the cancer cells produce way too much BCL2. What happens? They become practically immortal. They aren't dividing faster, they just refuse to die.
And this slide is just perfect. It shows you exactly what I'm talking about. We can do a special stain for that BCL2 protein. On the left, that's a normal follicle. See how it's blue, no brown stain? That's because normal cells in the follicle are supposed to die. They don't express BCL2. Now look at the right. That's a cancerous follicle. It is completely dark brown. Why? Because it is chock full of that anti-death BCL2 protein. This is how pathologists confirm the diagnosis.
All right, so we've seen the speed demons and the slowpokes. Now it's time to meet the heavyweight champion. This is the single most common type of non-Hodgkin lymphoma in adults. You have to know this one. It's called diffuse large B-cell lymphoma, or just DLBCL. It's a bit of a mixed bag. It's aggressive and grows fast, but, and this is a big but, it's also often curable.
And once again, the name tells you exactly what you need to see. Diffuse means the cancer cells aren't making nice little follicles. They just grow in big, messy sheets that wipe out the normal structure. And large B-cell, well, that's because the cells themselves are huge. They're much larger than a normal lymphocyte with big, obvious nucleoli. So diffuse, large B-cell lymphoma. Makes sense, right?
So what are the crucial, high-yield facts for DLBCL? 1, it is the most common NHL. Remember that. 2, it typically hits older adults, around age 60. 3, it usually presents as one big, rapidly growing mass that can pop up literally anywhere. And 4, the good news, while it's aggressive, we have our best shot at a cure, with about half the patients being cured by chemotherapy. The key gene to remember here is BCL6.
Okay, everyone, listen up. Pencils down, eyes on the screen. Everything we've talked about, it all comes down to this next slide. This is your exam winner cheat sheet. This is the slide you look at 5 minutes before you walk into your Viva. If you forget everything else, you remember this table. Ise bilkul ratamarlo.
Let's run through it fast. ALL, think kids, think immature lymphoblasts. Done. Burkitt's, 2 things, starry sky and the MYC gene. Super, super aggressive. Next. CLL, think older adults and smudge cells. This one is slow, indolent. Follicular, also indolent. Think nodular pattern and the immortalizing BCL2 gene. And finally, DLBCL, the most common one, aggressive. Think large cells, diffuse growth, and the BCL6 gene. Seriously, take a mental snapshot of this table. This is pure gold.
And I want to leave you with one final thought. Learning all these genes, MYC, BCL2, BCL6, it's not just about memorizing facts for an exam. This is the future of medicine. We now have drugs that can specifically target these broken pathways. So the question for you as the next generation of doctors is this: how will you use this knowledge to change the future of lymphoma therapy for your patients? Think about it. That's all for today. Thank you and all the best.
Namaste, everyone, and welcome back. I hope you are all ready because today we are tackling some of the most interesting cases in all of pathology. We are on the last stretch of our journey into lymphoid neoplasms. So please grab your chai, focus up, because we are about to solve some really serious diagnostic puzzles together.
Okay, so I want you to treat today not as a lecture, but more like a clinical puzzle we have to solve. We have 3 big cases on our list. First, the very confusing T-cell tumors. Second, the plasma cells that love to destroy bone. And finally, we get to meet one of pathology's most famous villains. Are you ready? Chalo, let's begin. So first up are the T-cell neoplasms. Ari, I know. This group can feel like a real mess. Yar, so many names, so many different ways they show up. But please, don't worry. We're going to untangle this whole thing together. The main trick is to just know the main culprits, the most wanted ones. And here is our most wanted list. First, we have the catch-all diagnosis, which we call the wastebasket. Then there's the great mimic, the ALK plus imposter, which can really fool you. After that, a very clear-cut case of a viral culprit. And finally, a type that loves to hang out on the surface, the skin invaders. Let's get to know each of these characters a little better. So, what do I mean by a wastebasket diagnosis? Well, think of it like this. You look at a T-cell lymphoma and you try to fit it into all the specific, well-known categories. If it doesn't fit anywhere, if it doesn't tick any of the specific boxes, you put it in this basket. Peripheral T-cell lymphoma, not otherwise specified. It's a diagnosis of exclusion. And the key thing to remember is that because it's such a mixed bag, the patient's prognosis is really hard to predict. That's a huge clinical point.
Now look at this. This is a very specific one, anaplastic large cell lymphoma. See those huge, strange-looking cells with nuclei shaped like a horseshoe? That's your hallmark cell. It's a massive clue. But in pathology, we always need to be 100% sure, right? So we use a special stain. And look at that strong brown color. That confirms it's positive for something called ALK protein. When you see those cells and this stain, that's your diagnosis. And remember this type often shows up in younger people and actually has a pretty good prognosis.
And here is our next case. Look at that cell. It might look like a flower, but trust me, it's a killer. These are malignant CD4-positive T cells, and they have these very weird multi-lobed nuclei that we call cloverleaf or flower cells. Now listen carefully.
Whenever you see a cell that looks like this in an adult, your brain must immediately think of one thing: the virus HTLV1. This look is almost a dead giveaway for adult T-cell leukemia/lymphoma. Okay, so we're leaving the complicated world of T-cells now. We're shifting our focus to a problem that starts with just one single evil cell: the plasma cell. The story here is all about how one rogue clone, just one, can go completely crazy and cause devastating problems all over the body. So here's the most important concept: the M protein. M stands for monoclonal. You see, your normal plasma cells are like a factory making all sorts of different antibodies. That's a polyclonal response. But in these diseases, one malignant clone takes over the whole factory, and it just starts pumping out massive amounts of one single identical antibody. This is the M protein. It's our tumor marker. It's the evidence of the crime that we find in the patient's blood. And what kind of damage does this one rogue clone do? Well, look at this. This is what it does to the bones. This X-ray is classic. Absolutely textbook for multiple myeloma. These are not spots from some other cancer spreading, no. These are literally holes in the skull caused by the plasma cells themselves. They tell the bone-eating cells, the osteoclasts, to go into overdrive, creating these sharp, punched-out holes. It's direct destruction.
Okay, for your exams, for your clinical rotations, for your future practice, you have to remember this. Please, just memorize it. CRAB. It's the key to diagnosing symptomatic myeloma. C is for hypercalcemia, because all that calcium from the broken bone floods the blood. R is for renal dysfunction, kidney problems, because those antibody fragments are toxic. A is for anemia, because the bone marrow factory is taken over. And B is for the bone lesions and pain we just saw. CRAB. Don't you forget it.
So we saw the X-ray, now let's go to the microscope. This is the bone marrow. It's supposed to be making red blood cells, white blood cells, platelets, but look, it's completely flooded, absolutely packed, with sheets and sheets of these malignant plasma cells. There's no room left for anything else. This right here explains the A in CRAB, the anemia. The factory for making blood has been hijacked. So how do we prove it? How do we find that M protein? With this test: serum protein electrophoresis. Look at the normal pattern. You see that broad, gentle hill? That's all the different healthy polyclonal antibodies. Now, look at the patient's sample. Whoa! See that huge, sharp, dense peak? That is the M spike. It's that one monoclonal protein, all stacking up in one spot. This is the smoking gun. It confirms it. All right, time to meet our final character. And this one is a true celebrity in the world of pathology. So I want you to forget everything we just talked about with T cells and other lymphomas. Hodgkin lymphoma, it's a completely different kind of beast, defined by one very famous, very distinct, and honestly, very evil-looking cell. But before we see this cell, let's look at its behavior. Hodgkin lymphoma is usually, how do I put it, more well-behaved. It tends to start in one area, one group of lymph nodes, and then it spreads in a very orderly, predictable way to the next node in the chain. Non-Hodgkin lymphoma, on the other hand, is wild. It's unpredictable. It can just pop up anywhere, anytime. This difference in how they spread is absolutely fundamental.
Now get ready for the great paradox of Hodgkin lymphoma. It's a real mind-bender. You'd think a cancerous lymph node would be full of cancer cells, right? Wrong. The actual malignant cells, these Reed-Sternberg cells, they are incredibly rare. Sometimes they make up less than 1% of the entire tumor. So what's the other 99%? It's just a big crowd of normal inflammatory cells that the bad guy is tricked into coming and creating a smokescreen.
And here it is, the star of our show, the one, the only, the diagnostic Reed-Sternberg cell. Just look at that thing. It's huge. It has 2 nuclei, like 2 lobes, and inside each one is a giant pink nucleolus that looks just like an eyeball. This classic ally appearance is what you have to find to diagnose classic Hodgkin lymphoma. I promise you, once you see it for real, you will never, ever forget it. But this villain is smart. It knows how to wear disguises. These are different variants of the Reed-Sternberg cell. On one side, we have the lacunar cell, which looks like it's sitting in a little clear space, a lacuna. You see this in the nodular sclerosis type. And on the other side, that funny-looking thing with the bumpy nucleus, we call that a popcorn cell, and I think you can see why. It's the key to the lymphocyte-predominant type. Recognizing these disguises is crucial for classifying the disease correctly.
So how on earth does this weird cell even survive? It's an amazing story of manipulation. First, it starts as a B cell that was supposed to die, but it somehow cheats death. It does this by hijacking a powerful survival pathway, often with help from the EBV virus. Then, it starts releasing chemical signals to call in that big crowd of other cells to act as its bodyguards. And finally, to hide from our T cells, it puts on an invisibility cloak, proteins called PDL1 and PDL2. This is a don't eat me signal. This cell is a true master of manipulation.
And that story brings us to our final and most important thought for the day. We just learned that the Reed-Sternberg cell's secret weapon is this PDL1 invisibility cloak that it uses to hide. So my question to you is this: what do you think happens when we give a patient a modern immunotherapy drug, a checkpoint inhibitor, that is designed to block that signal and rip the invisibility cloak off the villain? This connection, from a classic cell under the microscope to a cutting-edge cancer treatment, is exactly why this field is so amazing. Think about that. Fantastic work today, everyone.
Welcome, Bacho. Today, we are going on a really fascinating journey. Just think about it. We'll start with one single, tiny cell deep inside your bone marrow, and we're going to follow its story all the way to the very latest, most revolutionary cancer cures. So let's begin. Okay, so here's our plan for today. Pay close attention to the flow. We'll start at the very beginning, the origin story of blood. Then we'll meet a very clever manipulator, Hodgkin's lymphoma. After that, we'll tackle the whole myeloid family of cancers, zooming in on two important case files, AML and CML. And we'll finish with the best part, how we go from cracking a genetic code to finding a cure.
All right, first things first. To understand any of this, we have to start at the very beginning. I mean, right at the source, inside our body's own blood cell factory.
This is ground zero, the hematopoietic progenitor cell. You can think of it as the single mother stem cell. Everything, your red cells, white cells, platelets, everything is born from this one cell. And remember this, every single story of blood cancer begins right here, with a problem in this cell.
So what happens? Well, sometimes, especially with age, a mistake happens. A single one of these progenitor cells gets a mutation, and this creates a whole clone of itself. We call this condition clonal hematopoiesis. Now, listen, this is not cancer, not yet, but it's like the first little warning light on the dashboard, a hint that something might be starting to go wrong in the factory. Okay, now let's look at our first case study, a really, really clever and unusual type of cancer. A master manipulator, you could say. Let's talk about Hodgkin's lymphoma. This is the whole story of Hodgkin lymphoma right here. And it's a masterpiece of deception. Just look at this. The tumor has very few actual cancer cells. We call them Reed-Sternberg cells. So what is the rest of the tumor made of? Well, it's mostly made of recruited normal immune cells. The cancer cells release these signals to create a protective environment for themselves. It's almost unbelievable. This analogy is so important for your exams, Butcho. Think of these Reed-Sternberg cells as the criminal masterminds. There are only a few of them, right? But they recruit this whole gang of other cells to protect them. The cancer cell is basically hiding in plain sight, and it's being protected by the body's own cells. It's genius in a very evil way. And this is the map we use in the clinic. It helps us track where the disease has spread. It tells us how to treat the patient. Is it in just one lymph node region? That's stage 1. Is it on both sides of the diaphragm? Stage 3. This staging is absolutely critical. Okay, let's move on to our next big topic now. We're talking about the myeloid neoplasms. This isn't just one disease, it's a whole family of them, all coming from that same mother cell. It's actually quite simple, really. You can classify all of these based on what's going wrong in the factory. Is it a takeover by immature blasts? That's acute myeloid leukemia, AML. Is it a problem with quality control, making bad cells? That's myelodysplastic neoplasms, MDS. Or is the production line just stuck on, making way too many cells? That's myeloproliferative neoplasms, MPN. This slide just brilliantly illustrates the core problem of each disease category using our factory analogy. AML, the factory is overrun by trainee workers who they never learn their job, they just multiply. MDS, the quality control system is totally broken, so it's producing all these defective, non-functional cells. And MPN, simple, the machines are stuck in the on position, flooding the whole body with cells. Okay, so now let us open the case files for two of the most important myeloid cancers you're going to see. See here, Butcho, look closely at this blood smear. See these cells? These are the trainee myeloblasts. Look at that delicate chromatin. They are crowding out all the normal cells. This is what a hostile takeover of the bone marrow looks like. And look at this. Do you see those? Those distinctive needle-like things inside the cells? Those are our rods. This is a classic sign for this specific subtype of AML, acute promyelocytic leukemia. Don't you ever forget this. You see this, you know the diagnosis. Now let's talk about chronic myeloid leukemia, or CML. This is a totally different story. Here, the factory isn't taken over by trainees, no. It's just overproducing mature workers. What's really interesting about CML is that the cells can still do their jobs, but there were just far too many of them. Now, notice the difference from the AML slide we just saw. What do you see here? The whole family is here, from the young ones to the old ones, a complete spectrum of granulocytes. It's just that there's a massive increase in their numbers. So what's the culprit? Well, it's a genetic mistake. A piece of chromosome 9 breaks off, a piece of chromosome 22 breaks off, and then they swap places. This is called a translocation, and this creates a new fused gene, BCR-ABL. You can think of the protein this gene makes as a stuck accelerator pedal on cell growth. It just keeps shouting, go, go, go! And get this, over 90%, more than 90% of all CML patients have this exact same genetic mistake. This is the crucial point, Butcho. This one single mistake is driving the whole disease. So what happens with all that overproduction? It can't all stay in the bone marrow. It spills out, and the spleen becomes like a secondary factory, causing it to swell up. Just like this, absolutely massive. And now this brings us to the most exciting part of our story today. How finding that one genetic code led us directly to a cure. This is the magic of modern medicine. Instead of just killing all the fast-growing cells in the body, which is what old chemotherapy did, we can now design a drug to target the specific protein that's causing the cancer. We're not just fighting the disease anymore, we are actually fixing the broken part of the machine. So by knowing the exact genetic problem, like the BCR-ABL in CML, we can design a smart drug that just turns it off. And the results? They are fantastic. And it works for other cancers too, like that special type of AML, APL. We found its genetic problem, and now we have a targeted solution for it. And what are the results? Over 90%. With targeted therapy using all trans-retinoic acid, the cure rate for acute promyelocytic leukemia, a disease that was once a death sentence, is now over 90%. Think about that. So the crucial takeaway today is this. Understanding the fundamental science, this is the only real path to a cure. It's not just about passing your exams, it's about saving lives. We cracked the code for CML and turned a fatal leukemia into something manageable. So the big question is, what blood cancer will be next? That's up to you.
All right, everyone. Good morning. Good morning. Welcome back. Today, we're going to tackle some really fascinating and, I must say, very high-yield topics: the blood, the spleen, and the thymus. These concepts come up again and again in your exams and in the clinic, so we need to get them crystal clear. Cholo, let's begin.
Okay, let's just jump straight in with a clinical puzzle. Look at this. I mean, just look at it. This is a massively enlarged spleen, what we call splenomegaly. The patient comes in complaining of a dragging sensation, and this is what you find. So what on earth could make an organ grow to this incredible size? This one single picture connects everything we're going to talk about today, from the blood to the bone marrow to the organs. So let's start unraveling this mystery.
So our number one suspect for this massive spleen is a condition called primary myelofibrosis. You know, the name itself tells you almost the whole story. You have myelo, which means marrow, and fibrosis, which means scarring. So it's a disease where your bone marrow, the actual factory for all your blood cells, gets scarred up and, well, it starts to fail.
Okay, let's break down the formal definition. It's a myeloproliferative neoplasm. Myelo is your myeloid cells. Proliferative means they're overproducing. But the real hallmark of this disease is the obliterative marrow fibrosis. The marrow gets completely choked with scar tissue. And because the factory is shut down, the body gets desperate and starts making blood outside the marrow. That's extramedullary hematopoiesis.
And where does it happen? Mainly the spleen and the liver, which is exactly why they get so huge. Now, a crucial point, and I want you all to star this in your notes, about 90% of cases are driven by mutations in genes like JAK2, CALR, or MPL. This is a massive clinical clue.
Now this is what you see when you look at the patient's blood under a microscope. Look at those red blood cells. See how they aren't nice and round? They're shaped like little teardrops. We call these dacryocytes, and there's a great way to remember this. Just imagine they are crying because they've had to squeeze their way out of that tough, scarred-up, fibrotic bone marrow. This teardrop shape is a classic finding.
So how does this scarring even happen? It's a really interesting chain reaction. It all starts with cancerous megakaryocytes. Those are the cells that make platelets. These bad guy cells start pumping out a whole bunch of growth factors, like PDGF and TGF-beta. Now listen closely, because this is a concept students often get wrong. These growth factors then stimulate normal, non-cancerous fibroblasts to start laying down collagen. The fibroblasts themselves are not the cancer. They're just innocent bystanders being told what to do. This is a super important concept to grasp. Okay, so myelofibrosis is one major cause of a huge spleen. But let's shift gears and look at another kind of weird condition. This one involves an immune cell that's gone rogue. We're talking about Langerhans cell histiocytosis, or LCH. It's an unusual clonal, meaning cancerous, proliferation of these Langerhans cells. And just like before, there's a key molecular story here. More than half of these cases are driven by mutations in a gene called BRAF.
So, have a look here. On the left is the histology. You see these Langerhans cells with their funny-looking nuclei. They're folded or grooved, almost like a coffee bean. This is a good clue. It's suggestive. But the image on the right, oh, this is the money shot. Under an electron microscope, you see these things called Burbeck granules. Don't they look exactly like little tennis rackets? This finding is pathognomonic. That's a word you need to know. It means if you see this, it is Langerhans cell histiocytosis. End of story. You must know this for your Viva.
Now clinically, LCH is a real chameleon. It can present in wildly different ways. In infants, it can be a really aggressive multisystem disease called Lederer-Saiwi disease, or it could be just a single lonely bone lesion called an eosinophilic granuloma. And then there's a classic triad you absolutely have to memorize for your exams, the Hans-Schuler-Christian triad. This involves holes in the skull bones, diabetes insipidus, and bulging eyes, or exophthalmos. It's a classic for a reason.
Archa, good. So now let's circle all the way back to where we started our investigation, the spleen. To really understand why it gets so massive in these diseases and what the consequences are, we first have to quickly review what the spleen is supposed to be doing in the first place.
Okay, let's do a quick fire round. The spleen's 4 main jobs. Ready? First, it's a filter, a garbage disposal, eating up old blood cells. Second, it's an antibody factory, protecting you from things in your blood. Third, in an emergency, like in myelofibrosis, it can go back to its fetal job of making blood. And fourth, it's a storage unit, especially for your platelets. Understanding these normal jobs is the key.
And here is our star patient again. But now let's look with more educated eyes. You see those pale, wedge-shaped areas on the surface? Those are splenic infarcts. And this is a perfect illustration of what happens when an organ grows too fast. The spleen literally outgrows its own blood supply, and parts of it just die off. This is a very, very common complication you'll see with massive splenomegaly.
Now please, everyone pay close attention here. This is a critical distinction that students always mix up. Splenomegaly versus hypersplenism. They are not the same thing. Splenomegaly is an anatomical finding. It just means the spleen is big. You can feel it. Hypersplenism, on the other hand, is the functional consequence. It's what the big spleen does. Because it's so big, its filtering and storage functions go into overdrive, trapping way too many red cells, white cells, and platelets. That leads to low counts in your blood. One is a sign, the other is a syndrome. Very important.
All right, let's move on to our final organ for today, the thymus. I always like to call the thymus the university for T cells. This is where our T lymphocytes go to get educated, to learn how to tell the difference between self and non-self. But like any organ, it can also develop tumors.
So let's do a little compare and contrast here. On the left, you've got a benign thymoma. See the cells? They're kind of spindle-shaped. They look pretty bland, pretty orderly. Looks quite tame, right? Now look to the right. This is a malignant thymoma. The cells are more polygonal, more angry-looking, and they're mixed in with all these small, dark, immature T cells, which we call thymocytes.
The histology can sometimes be tricky, but it's the behavior, its ability to invade other tissues, that really defines it as malignant. Okay, everyone, pens down for a second and just listen. If you remember nothing else about the thymus from today's lecture, you remember this. This is an extremely high-yield association. I pretty much guarantee you will see this in your exams. A huge chunk of patients with thymoma, up to 45%, also have myasthenia gravis, that autoimmune disease that causes muscle weakness. So what does that mean for you as a future doctor? It means if you diagnose a patient with myasthenia, you absolutely must check their chest for a thymoma.
Okay, class, we're nearing the end of our time. Before the bell rings, let's do a quick, high-energy revision to tie all of these myeloid concepts together. Let's make sure this is all locked in.
This table simplifies it all beautifully. Think of it this way. Acute myeloid leukemia, or AML, that's a marrow full of immature baby cells, or blasts, because they can't differentiate. Myelodysplastic syndrome, or MDS, the factory is working, but it's making faulty, dysplastic products, so your blood counts are low. And finally, the myeloproliferative neoplasms, like the myelofibrosis we started with. That's a factory in overdrive, punking out tons of mature cells, all thanks to those activated kinases like JAK2. This leads to high counts, and of course, that massive spleen. 3 very different problems, all starting from the same myeloid lineage.
So I'll leave you with this final thought to ponder. Today, we've seen how one single point mutation in the JAK2 gene can lead to a bone marrow that's turned to scar tissue. We've seen how a tiny tennis racket organelle inside one type of cell can lead to widespread disease. And we've seen how these tiny, microscopic changes result in a spleen so large it fills a person's entire abdomen. How does that happen? How does a single microscopic change create such massive, macroscopic disease? That is the magic and the challenge of pathology. Your job is to always connect that molecular event to the patient sitting right in front of you. Okay, that's all for today.